The last group of that we envisaged that we would be mentoring is the consultants in difficulty. It's obviously going to be the most challenging group. Simon in his talk alluded to some, although to some of the issues raised. But I think hopefully Shyam will be able to give us some more ideas. And thank you very much, Mr. Kolvekar.
Oh, hi, thank you very much, Mahmoud. I first apologize to everyone if I unknowingly, knowingly hurt or send something harsh word. And that's not my intention, because it just makes it a bit more interesting if you are a bit more dogmatic about it. But I have no intention to hurt society. Sorry, Simon, Al Presidente, I'm sorry if I've hurt anybody of your team, and there's not an intention, but it's just making it more interesting.
Sorry, Shyam, should we let you speak even now after this health warning? We take a vote now.
Just say thank you very much. That was very enlightening.
Thank you. Okay, Shyam, sorry to interrupt. Okay, share your slides.
Okay, I think it is extremely difficult to be in the difficulties, and it is the worst thing for anyone. And that's why when I joined as a trustee, I always thought we should create some system which can protect and salvage. Because I still believe 90% of us are nice people. There are some 10% have issues, but overall we can fix everything. We can't be 100%, but almost salvage everywhere. Strangely enough, our society, our specialty is very tiny. We got only 254 last count. There are 6 cardiothoracic, one of them is me, and there are a few more around, and 140 thoracic surgeons in UK. We have 66 million population. It's a very small specialty. Almost 1 in 8 consultants have some sort of a difficulties. And in the past, surgeon-specific mortality was used not by society as a weapon by some of the unscrupulous fellows to set the scores, like these warning sign of yellow, orange, red did affect it. We live in a litigious society, and as a society of cardiothoracic, as a cardiothoracic surgeon, we are our own worst enemies. Not because we are bad people, we are perfectionists. We are a new specialty of any surgery because we are 50, 60 years old. Before that, we were not doing much. So that's the reason we've been very stringent about it. Second thing, it could be a God complex because we stop a heart, start a heart. So perhaps that makes us a bit more keen and a bit harsh. And then everyone gives an example of Shipman. And that's why I said, Shipman, if he was a member of parliament, he would have finished his constituent who were troubling him. Unfortunately for us, he became a doctor and he started all his regain of getting people rid of people, only where he got caught when he's trying to take their money. Bristol Inquiry, I have a lot of choices word, but I'm not going to say it because I'll upset a lot of people. I feel in Bristol, surgeons had their fair share, but I think the people who escaped were the one who referred it. As a specialty, as you remember, we get patients referred to from other specialists. We don't generate our patients. And from coming from small village in India, if you're a doctor in a city, there is a little fellow who sells you cigarettes and tobacco. And all his village people come to him and he said, oh, go to Dr. Loubani, he's a fantastic surgeon. And he sends us 6 patients there. None of them come back. He's not going to send those patients, 7th patient to Dr. Loubani because the 6th has not come back. But what were the Bristol pediatric cardiologists were doing? Why they were keep referring these patients? There was a high mortality. And nobody asked that question, not even the society. I was that time was working with people as SR, and I have seen people going through the cases. And I felt that this was just a witch hunt against us. We are party to it because once we cut open someone, we are responsible. But who is controlling this cardiologist? And there are lots of stories about it, but I don't want to say this in open forum and apologize if I hurt some. There was a political will to control us at that time, and the word governance came to us. There's a good and bad to it. Good thing is that I think we got all looked at our practices and made us much more savvy. Performance of a surgeon, I think we only focus on his surgical performance. But as a surgeon, first thing is we see patients, we assess them, we speak to them, we speak to our colleagues like anesthetists, junior doctor, nurses. All these affect your performance. Performance on the table is definitely important, but how you manage your patient, how you manage them in clinic, how you manage even giving them a call. Worst case scenario, how you manage breaking bad news. And these are very, very important structure part of being consultant. I think most often when I was a junior, I used to think that doing an operation is the greatest achievement. Everything else doesn't matter to fall through. It's not. We got to be good at all those 4 parts: work, context. Health of us is also important. If you are suffering from angina or a cataract or tremors, that affects. And behavior, we'll talk about it a bit more. This is from NCAS. So they adopted this kind of a triangle to tell clinical ability and competence is in the center of that. Everything is interrelated. See, like behavior, misconduct, clinical, I think clinical is more important, and health concern. If you join, you see the structures are overlapping, it affects us. So when you look at someone's bad performance, we have to look from all these points of view. And that's the reason it's very important to assess the person from all directions. There may be some issues which can be resolved. So doctrine difficulty can be divided into different parts. There is one doctrine difficulties because of workload. During COVID time, we realized that some of our intensivists, anesthetists, and some other specialists drafted into unknown territory. Can you imagine intensive care is not bad enough, but you're getting dermatologists managing your intensive care unit. It was difficult. But that's why doctors were stressed. But I think there's an unusual experience. But pressure of work, constant maintaining the numbers, problems, complaint, SUI, litigation, inquiries, pressurize you. It's sometime in your mindset. You may be anxious type and you take it much more seriously. Then comes with doctor with difficulties, because that's also a doctor in difficulty. I have seen it, this cataract, early development cataract. One of my senior surgeon whom I worked with, I won't mention his name, but every time he went for a lobectomy, he always ended up having pneumonectomy. Or if you're going for segmenting, it's because he had a perception of depth was gone because of cataract. And even though we used to do open surgery those times, he used to do that. And I didn't realize that time. I just thought I'm just a humble registrar. I'll just look at it and fix it. But eventually we realized that he had a cataract. Once he fixed the cataract, everything got better. He developed his vision. Rheumatoid arthritis, there are some of the famous surgeons are affected with it. It makes your finger movements difficult, tying knot. You could have loose knots. So these are health problems. And you could get tremors, you could get early Parkinsonism. These are important things to look for. Alcohol dependency is a worse, which is quite common. We don't realize. I think people know there are some famous surgeons had issues, and now they are not practicing with us. But that's a very serious thing, and it should be dealt with at the beginning. And I think, as all of you know who are listening, if you're caught with the smell of alcohol in any premises of NHS, they can terminate you from your job. It's that serious. So be careful. After parties, just going to see your patient may not be work for your advantage. And home and personal life, because by the time we become consultant, we are around 40 middle-aged men and come with the baggage. And then we spend more time with the hospital staff than our spouses. And that can affect, and there are divorces, children issues, financial issues. It's all personal thing come, and doctor could be in difficulty because of that. And then there's a third group, difficult doctors. I think we all know one or two in our career, or probably still know them. I think it's a behavior thing. I think most of what I've seen is these people are a bit more insecure. And that's why they take away the insecurity by behaving with a bravado, and people have gossip and talking. I think confidentiality breach is a very, very serious thing, because patient or anybody comes to us, they tell us the utmost secret. They will not dare share with their spouses or close one. They share with you, and if we share with someone else, it's really, really criminal offense. But some people do that, and it's very bad, especially if you're seen in a lift when we chit chat. You got to be very careful in a lift. There are patients and somebody else, and some people just don't have insight. They just carry on doing what they think they've done it. I think things have changed. When I was a registrar, my boss covered me and he said, Shyam, I'm around, I'll cover you. And then when I wanted him, he was halfway to Switzerland. It was quite a long distance European cover, but somehow we survived that. You cannot do that anymore. And as Simon said, private practice, especially in the cities, is a source for any evil. If some in proportionate anybody has a high private practice, he becomes targeted and can be in trouble. Having private practice is not bad. It's a good thing that somebody value you and try to pay you money, but you should be very careful. And I personally, every time I suggested, I never worked, every unit should have a group practice. All the members of the could join in a private practice and do it together, so that even if you go on a leave, the money is earned and everyone is safe. No patients will go to any other side. But I tried, and I think being a different breed as a surgeon, we never like to have a group practice. Orthopods are fantastic. They divide each joint and they all join together, one shoulder, one elbow, knee, and they make all money. I think we had a good talk on the color of skin, but it does affect. It in a management role, and my different hat, I've been on some of the fitness to practice committees for GMC, and exclusively the cases I did, they were all outsiders, as you say. They had a different color of skin, and there was issue, but it could be communication. I'm not making sure that I think they did good or bad, but it was just become very obvious to me. So it is an important part, especially if you're surrounded by, but I think compared to a lot of countries, Britain is one of the least racist place. So I always said that it's bad for a country to have a failed consultant, because country has taxpayers has paid money to get you educated. Not, I think the fees we pay now is different, but those days we used to pay £850 to be going to medical school, and then the taxpayer chipped in, make you consultant. By 18, you go in that ladder. By around 40, we become consultant, and then become a jobless. It's very sad. We are de-skilled. We can do cardiac surgery, but nothing else. You rather sit on a committee, or unfortunately go for public health. See what happened to public health. They selected all the people who are kicked out on the regular services, and now they had abolished that department and become different ones. So what I'm saying is, we must salvage every single person's career if we can. And if they are beyond help, I think we should give them a good advice and send off. So I think there are a lot of talk on mentoring. So I'm going to go through quicker with this. I think with mentoring, we should also have a counseling service, because it's anxious time. Till last day, you were a registrar, everyone took your responsibility, and now you're a consultant, and then you've got to suddenly to take all responsibility. So you have to go through this process, and we had a good talk on this, but it's part of it. That's why I mentioned it. And there are different systems here, but I personally feel that mentoring is important, and every consultant, because in UK, we have a social democratic system in medicine. Everyone is equal. That has good thing if you're a junior, because nobody is telling you what to do, but it's bad if you're senior, and also it's bad for unit because the checks are a bit less. So I feel the system has to have a little hierarchical, like a military grade. Then probably we have less mishaps in medicine. So I think benefit of mentoring, I'm just going to skip through it. I added this up if somebody has not covered it, but I think mentoring, for a mentee, having mentor always increase self-confidence. Somebody watching him what you do and find out any bad habits you have, and also his skills get better. And mentor, we learn from our mentee. I think all of us are mentor one way or other. You teach your registrar, you teach your students, you teach your junior consultant, we learn. And sometimes we also learn how wrong we were and we pick up from them. So it's a bilateral part. Getting mentor, I think Simon spoke about it, how to get it, but I think this is the hospital-based one. I'll tell you about what my ideas are. And I think this is what I feel, that SCTS should sort of under umbrella, we should get a group of senior surgeons. I think luckily Ramesh is there. Ramesh was my SR. I learned a lot from him. He's a fantastic surgeon, very dedicated. And I'm happy that he's joined us a talk, and I'm going to definitely ask him to join this group. So anybody senior enough or people near retirement, I said retirement for the reason is that you have a less conflict of interest and you will be much more helpful to people. And I think we should create a group of people. It's purely voluntary and we get trained regularly to how to do it. We match up the location because it depends on where you live, because it shouldn't be much traveling. Duration as per requirement, and then you produce a report and then you have action plan to it. The principles are same. Patient safety is most important. Also the safety of the colleagues and the doctor who's involved. The management consultants, I think if they're in difficulty, they have a different type of learning. But for doctors, it's pretty straightforward because at the end of the day, the patient is important and his safety is important. So that's why by taking action, we've got to be very careful. So if doctor in difficulty or consultant in difficulty, the unit chief, unit lead, medical director should contact society or a mentoring team and say that we have issues before you do anything, before suspending or we call it as a gardening duty, everything. You need to look for what it is, because once the person's suspended, he's totally demoralized. If he leaves the campus, he gets de-skilled. So before that, we should do it. So you visit them, they assess what the problems are and study it before coming. Then they have meeting with the doctor who's in trouble and along with their clinical lead or his friend, and have a sort of open, frank discussion what's going to happen. If you want, make it more professional, we could have a little loose contract about what's agreed and things like that, so that your presence, the people who come in the hospital should have honorary contract, which should be easily done. I was told that if two medical directors discuss, because we all work for NHS, so they can we cross cover each other. So mentor goes there, he scrubs in it. First, before that, he checks all his list, discuss the patient, ask for him what treatment, because you need to understand how the consultant difficulty thinks about what the decision making, because you can even spot on what's happening. After that, you scrub and assist with him all the procedure. Please, at this minimum 1 week, go in theatre, stay with him, assess every stage of it. Then attend the ward round, how he conducts the ward round, how he conducts with his colleagues. Every step is important because it does affect us. How we come across with the theatre staff, whether you start throwing instruments, knives and other things. There are people, but nobody does that anymore. But some of consultant I worked with, it's barely stabbed one of the other registrar because he was not holding the incision properly. So I think those things are gone. And then also it's very important to see his interaction MDT, because that's where we see how they are cohesive. You listen in MDT, how they come across, how they choose a patient, how they select a patient, because the root cause is there. At the end of the week, you have a sitting again with his friend or a clinical lead and have a just debrief that what you found. And then the mentor goes back and prepares a report. Before he submits a report to the clinical lead and our mentoring team, he need to send that copy to the surgeon who's affected. He has to look through it because it is all open. There is no secret, because the secret makes it more paranoia and makes it worse. And once they look through that, and if there are suggestions, he thinks your interpretation wrong, you can take that on board, but you shouldn't change it just because the surgeon is telling you to. And then send it to the clinical lead, other things, and then you give a recommendation. Say that, look, this guy is good enough for CABG. Please keep other thing away. Fair enough. Or you say that if he wants to do complex cardiac surgery, he should have a proctor or mentor all the time, or he should do in a 2-surgeon team. All these suggestions we can give, because the person who's mentor is a senior enough to assess these and advise them. And it works well, because choosing senior works well, because being a senior at that level, you have worked with the people and they know how you work, and it has much more weight to it. And because it goes through the SCTS, it has that sort of a governance role to it, that it is above the board, and these are not a sort of wind chant on sort of signing off someone. The follow-up to this is usually sort of a resolution and update, see what happens, and you can have follow-up up to 6 months and a progress report. You have a direct communication, you don't have physically good. I think Zoom and other Starleaf have taught us that we can do all the remote communication. So you can and update on that. And a regular meeting with your mentee and see the progress is. Then the second role, if that works, that could resolve a problem, it can come to term. But then there is another thing where you need a mediator involvement. This is a bit more serious. I'm sorry to use a St. George's word. I should have deleted it, and I'm regretting it. I think they have been a hard time they've gone through, the colleagues of ours working there, and I shouldn't use that name. But it's a toxic environment unit. I think I worked in a unit where 2 consultants couldn't speak, let alone walking in around. They used to wait for each other to go. Only thing they didn't do it is a fist fight in the middle of a ward. But that's the worst. Can you imagine for trainees and other colleagues to be found? But I think that things are getting less and less. Some units have this groups and gang culture. I think if you look at the St. George's report, you realize they have a group of people collecting, fighting, and almost harming patient, not knowingly, but unknowingly, because putting their foot down to do their list and canceling someone's. I always say, we cannot be best buddies to everyone. It's difficult. And if you are, you're lying to some of them. But we should never have enemies. And I think it's very lack of communication or miscommunication makes the animosity. I don't think 99% we are good. We know each other. If you sit with the person you hate the most, have a cup of tea and talk, you realize, I don't know why I was hating this guy. So I think it's important to do that. Sometimes face-to-face might resolve, I think. But important thing out of all this is a strong leadership. The unit which failed, we have a lot of problems with their colleagues, is where the leadership is failed. I shouldn't take St. George's name, but if you look at it, their clinical lead once was a cardiologist, then it was an intensivist, and some strange person on the street was leading the unit. What it means is that they couldn't get on with even appointing their own lead. And that tells you about leadership. Strong leadership resolve everything. We are a great example. With 3 big units joined together. And I think credit to Steve Edmondson. He just banged our head together and we're all together. We have no disruption problem or anything to anyone. It's because of strong leadership, because you got to be firm at some time, resolve a problem. We are not the best buddies, we all are friends. If you see here, we run the 10 theater. If there's a crisis, there are always 2 other surgeons who will go and give you a hand. That kind of environment to work. I look forward to coming to the hospital. The day you hate to go to work, the problem starts with them. This is the important warning sign when we are having a problem with the unit. And now about this surgeon-specific mortality is absolutely had a problem, because there are people who are simple soul, they keep operating, never say no to it, and had a mortality, and they're getting their cards, yellow card, orange card, and demoralized. The other smart people, they put a balloon pump before taking to patients, so become a salvage procedure. People, and there is a mortality, we have this little caveat. If patient goes behind you after 7 days to other trust, may not locate the mortality. So people sort of quietly gamed around to reduce their mortality, who were smart. I think, I'm not saying they're bad, but they managed to work around it to get their score low. And there are some simple soul, working hard, working people, they just keep doing it and then got these cards and restrictions. And I think this whole evil thing was one of our predecessors got it all us to do a surgeon specific. Of course, government like that because they like the league table to play with it. But I think now present David and all the governance, I think lead and Simon, I think it's the Simon's leadership made it unit specific mortality. And I totally agree with that. And I could tell you, there was the same thing what we had a problems on the East Coast of America in the mains and that area. The New York Times published this league table and stuff like that. So since then, they created this surgeon-specific mortality. Suddenly, most of their high-risk patient has to leave that region to go somewhere like Utah and some other places and get their operation. It was a very inconvenience for patient because nobody was doing a high-risk patient where we actually make a difference. Then surgeons are very smart cookies. What they invented, anybody had a mild or moderate MR, they started putting ring in it so that the CABG, which was a sort of a named procedure, is no longer a CABG. It's a CABG plus thing. So if you have a mortality, you are excluded. And there was a sudden epidemic of mitral repairs across the East Coast. So much so they hired the Harvard professor to assess it. And he created a report saying that this is all related to surgeon specific and their powers to be made a decision that we should make it unit specific, because unit specific thing is very good. Because if you got someone who's underperforming, it's your best interest to help him to make him better. So by doing it, you become a cohesive team and you improve yourself. Because if there is a bad ship in it, I'm not saying bad for reason, but it could be we had a few drinks or something and he's the wrong choice and selected. But if you give him a hand, he might perform better. And that's why unit specific has a lot of advantage. It takes away stress from surgeons. It took almost 20 years to train us, and then making your one day you're suspended and gone is not a good thing. So unit specific, Simon, thank you. You did the great job to introduce that. It's quite brave in spite of being government on our back. I think mentoring structure for unit, I think we discussed about junior consultant. I feel we should pair it. Every time you appoint a new consultant, you should have a senior consultant paired with them. The pairing is loose, but they should be paired with junior consultant, senior consultant with the same sort of interest, mitral to mitral, aortic to aortic, complex things, etc. And you have a team. And that works better. Every complex case, two surgeons be doing it. I think we should almost make it like a mandate that if it's a complex case, you have two consultants, because then it works better, because two heads, two senior people works well. And I will go ahead, and I think society should put a foot down, then any new consultant appointed, it should be mandatory to have a mentor, at least for first year, because then your safety. And it's the responsibility of clinical lead or director to have that written in contract, that first year of your consultant job, you will have a mentor. The mentor will go through your case selection, go and give you at least advise what you do. He doesn't have to scrub for all cases, he should be around. And when he's doing on-call cover, it should be, there is a second person on call to cover him for first year. It's not, you're protecting him and you're protecting your patient. It's very important. You cannot just appoint someone consultant and give him a free ride until he collapses. So I think it's important we have that. And I feel we should make that in unit structure, that this is a required structure for it. I know I stress it a point, but I think it's important if a society should, when we give a college rep, they should make sure that when we give a report back to the college, there should be mentioned that this person appointed and this guy is his mentor. It's very important because we know someone to blame, and I'm not saying blaming, but someone to be responsible for the junior doctor. Because for junior, it's fantastic. You have someone to go for in a new unit you're going in is amazing. Other steps. I think in London it's possible. Swapping consultant. During COVID time, we had some of our neighboring unit people worked here. They were so happy. We had to literally kick them out of unit because they didn't want to go to their own unit. So what I mean is, it's the environment. So if there are issues in a particular unit, sometimes you do temporary swap because patients belong to NHS. We don't own them. If you swap it, at least he's in a better place with the better colleagues, and see how long it goes. And if it might just resolve, or he may think that, shit, my unit was better, I'll go back and it will be nicer to my colleagues. So it might work in that way. Other things is very responsible. Anger management. There are people, especially they have anger issues because they're always good when they're not angry. But once they get angry, they go totally ballistic, and then you have bullying and all these things come. So and he may not even know that he has this issue. So those courses are very important. One of our colleagues in the past, I won't mention name, he was done for bullying. Eventually, he agreed to go for anger management, and now he's a totally different person. I can't even recognize him as the same person a few years ago. So it works well. Time management is for people who are very chilled, relaxed, and not precise. Because time management is important because your patient will affect. You're not very careful managing your waiting list. Patient will wait and they may die on a waiting list. It's very important. That is a very good sort of educational thing people should do. Personal development courses are important. Breaking bad news. Because I'm cardiothoracic, I did in detail 3 days with a cancer, but all of us, we do it because sometimes we are very bad at speaking to families when things are going bad. It's the biggest thing. You know, when somebody died, the loved ones like to hear from us. If you make a mistake, when you accept it, they realize you've been through worse than they are, and then usually gives them a more closure to it. Communication skills, I think there's a spelling mistake, is important because we appoint so many people from different globe. Empire spread almost 2/3 of the world, so you get people from Middle India, Africa, so many other places. We are okay. We had English as our language there, we learn medicine, but some places medicine they didn't learn English, so they have a problem because especially Europeans, it's very difficult to understand some of our registers. So I think we need to put them to a communication skills, especially English thing, because majority of patients are there, English. And I hate this translation software on telephone. My God, if that is we use in any negotiation, then anything will not go through. I think having those translators are good. I know it's a cost, but it's important because having family member as translator is a recipe for disaster because you don't know what they're telling them. But that is also important. And if somebody is really in trouble, has a lot of shakes and have a problem, you should reduce their operating sessions and probably give them academic involvement. They are safe in a lab. We used to call it in the past, to become a professor, there's a sign that you have been a troublemaker in theater. But what I mean is, we should use their skill for different reasons. And managing waiting list and patient communication is very important. And if consultants fail in that, that means we don't have insight. It's very important managing that. I think these are NHS offers you these practical advice. I think these are PPAs are very good, but I think it's very difficult to find where you find them. But there are resolution is there. There are a lot of upset. Our hospital, Bath Trust is very good for people, especially for people working there. There are a lot of support, counseling support, and they're very good. Help if there are problems, like you have problems, like a personal problem, health problem. They're very, very helping. I think always look for health if there are performance. And I think clinical performance should be reviewed. We got appraisal, then GMC does 5 yearly. These are important things. And health, I think we should all have a health check. If not, at least look after your health, because we may not even know it. The indigestion you felt could be angina. And I think you'll have to always decide which colleagues you're going to get your CBG done. It's very important. If you choose him, that means that's your mentor. Most important, we're coming to the end. Patience is virtue. I think we should be patient with our colleagues. Of course, if he's really dangerous and he's a shipment in making, of course, he should be staying at home. But otherwise, we should have patience, learn what the problems are. It can be always resolved. Talking will resolve. The problem in Middle East peace never happened because two parties involved in problems and never came face-to-face talking without American mediator. If you have a problem, sit together, talk about it. Good communication resolve most of the problem. If you can't resolve, then you have another resolution to pass. Good Medical Practice is a good book to go. I think this is what all we are controlled by GMCs. It's strange, isn't it? We pay General Medical Council fees and they usually show us the door. Very strange, but we need someone to control us. Thank you very much. If I said inadvertently to anyone, that wasn't my intention, and I'm sorry.
Thank you very much, Shyam, for sharing your thoughts and ideas on how to go forward with this very difficult topic, actually. Do you mind sharing your slides? Thanks. Very difficult topic of consultants in difficulty. And as you highlighted, it can have many aspects that lead to it, and then you need all the resources you can have to try and resolve it and get people back on track. Can you unshare your slides?
Yeah.
Sorry, to get people on track.
Yeah.
And I wonder if any of the attendees have any comments or...
Yeah, Mahmoud, just Simon here.
Yes, please.
Sorry, Simon.
One of the things, it's not just about equality and diversity. We've also had it raised that nepotism can be dangerous to organisations where you appoint friends or like-minded people. And so whether you're Johnson & Johnson or SCTS, it's really good to have a variety of opinions. And this is a great example where Shyam's been elected trustee and he brings that variation to the committee and his approach to things. So Shyam, excellent presentation. You've articulated so many of the issues that we face, and thank you very much indeed. It's good.
I mean, do you think Sam and Rajesh, who's going to be the future president, do you think this is something that the SCTS should be involved in or gets involved in, or do you think leave it to other organizations?
I think the current generation of young consultants would really benefit from a mentor, whether that's internal or external. But it would be, we just want to avoid our junior colleagues getting into difficulty, and it's happening too often. So I think we should provide that resource and try and keep them on the straight and narrow. In terms of visiting the units, that will be up to the trust to invite us in terms of being in theatre and assessing people, in practice, as it were. You would hope that their own unit could do that, but that doesn't mean that we shouldn't provide that service.
Thank you. Any comments, Rajesh, to add to that?
No, I agree. I think the business of providing mentorship for early years consultant and new consultants, I think is a step which we have to take. How we do that is for discussion, but that's prevention is better than cure. I think that's number one. The formal role of SCTS in engaging or supporting consultants in difficulty requires a little bit of thought, really. At present, I'm sure we will hear, it is done in partnership with the review mechanism, etc. And that, I think there should be a role, but what kind of formal role, requires a little bit of discussion, consideration, thinking through, because clearly SCTS cannot indemnify these mentors. That's a contract between the trust and the mentor in terms of indemnity. But SCTS can clearly, identify who are the mentors who can be considered. So it just requires a little bit of thinking through, really.
Absolutely, I agree with you. There's so many issues to consider in trying to set this up. And the more you think about it, the more you think about other things that need to be considered. I know Shyam and myself have been involved directly with reskilling of surgeons who have been suspended for a period of time, and it was with my involvement was to fulfill a prescription that was written up by the practitioner performance advice from NHS resolution.